Hello, my name is Charles Matrosic, and today I will be discussing our investigation of the feasibility of adaptive treatment replanning using EZFluence. During some patient treatments, large day-to-day anatomical variation can warrant the replanning of the treatment. This replanning process often takes multiple days due to the requirement of a new IMRT patient-specific QA measurement or a new patient simulation. This multiple-day delay can be problematic in some cases, since further patient interfraction motion can occur during this replanning process, which could invalidate the new plan and also warrant yet another replan. The goal of this work was to investigate the feasibility of a fast, adaptive replanning workflow using EZFluence, a commercial 3D conformal radiotherapy field-in-field optimizer developed by Radformation. To investigate this, we tested three scenarios using the data from previously treated patients. The first was a 3D CRT bladder treatment, which showed large day-to-day variation in bladder filling. The second was a two-target VMAT lung treatment, which showed more day-to-day setup variation than was assumed during the treatment planning process, which required an additional PTV expansion. The third case was a multimetastatic thoracic treatment with two targets, one in the right rib and the other in the right lung. The time required to replan each treatment was recorded. To confirm that the EZFluence field-in-field replan was feasible, the corrected PTV D95% was compared between the replanned and the original plan. And also, a potential replanning workflow was developed to check if it would be feasible to do this replanning online with the patient on the table. The first scenario investigated was a bladder field-in-field 3D CRT treatment planned using EZFluence. As displayed by the bladder contours in yellow in each of the CTs, the patient's bladder target showed large variation between simulation and each treatment fraction. A corrected PTV was created based on the expansion of a union of the bladder contour in each of these three CTs to better capture the contour variation. This treatment was then replanned to target the new PTV using EZFluence with the same beam arrangement as the original plan. The second scenario investigated was a two-target lung VMAT treatment where daily CBCTs showed large day-to-day variation of the tumor position during breath holds. An example of this variation is captured by the displayed CBCT for one of the PTVs. The PTV was expanded further in both the superior and inferior directions to account for the additional uncertainty. The VMAT plan was then replanned as a field-in-field plan targeting the corrected PTV using the EZFluence VMAT to 3D plan conversion feature. The third scenario investigated was a multimetastatic thoracic VMAT treatment with a tumor in the right lung and right rib. Each VMAT plan was replanned using EZFluence to investigate if this treatment could have been completed using field-in-field as opposed to VMAT. Axial views of both the original treatment plan and the replanned treatment for the bladder scenario are shown here, with the original PTV being shown in teal and the corrected PTV being shown in magenta. The corrected PTV D95% improved from 96.9% in the original treatment plan to 100.8% in the replanned treatment. This came at the cost of an exceeded bowel dose D1cc limit due to an overlap of the bowel contour with the PTV. Sagittal views for the original treatment plan and the replanned treatment for one of the two tumors in the two-target lung treatment scenario are shown here, with the original PTV shown in teal and the expanded PTV shown in magenta. The corrected PTV D95% improved from 97.5% and 90.7% in the original treatment plans to 99.6% and 100.9% in the replanned treatments for the two PTVs. This improvement in PTV coverage came at the cost of increased lung minus GTV V12.5 gray and heart D0.1 cc. Note that although these OAR doses did increase, they did result in doses well below the clinical limits. A comparison of the VMAT and field-in-field treatment plans for the multimetastatic thoracic scenario are shown here. The EZFluence planned field-and-field treatments did result in similar quality to the original VMAT treatment plans, although they did result in higher OAR doses, but once again, these doses were below the clinical limits. A potential replanning workflow is displayed above. EZFluence allowed for the creation of a treatment plan in 11.2 minutes on average, and all other estimated times were based on clinical experience and data. This workflow enables the online adaptation of a patient treatment when paired with an abbreviated approval and physics check workflow. And note an advantage of this workflow is that it doesn't require any additional patient-specific IMRT QA or a resimulation of the patient. EZFluence showed potential for fast and efficient adaptive replanning for unique cases that exhibit interfraction geometric changes that compromise treatment quality. Further work is required to test additional scenarios and also to optimize the overlapping OAR sparing in treatment plans. This method could provide a useful clinical tool with minimal alterations to clinical workflow and the equipment used in the clinic for unique patient cases that require fast replanning due to relatively rapid interfraction anatomical changes. We would like to thank the following individuals and groups for their assistance and support for accomplishing this work. We'd like to encourage you to view our poster in the ePoster virtual library for the joint AAPM comp meeting. And thank you for your attention.